Still on the issue of funding, because I mean, we've seen the trade war that's going on, and of course the developed economies and their new economic realities at the moment. So I think it also means that those countries that are also relying on external funding will have to look inwards. And I know that there's a basic healthcare provision fund, and that fund, how is it doing, and where are we deploying the fund that is coming into that system?
Thank you very much, and also to appreciate the comments of other panelists. The Basic Healthcare Provision Fund, as we've known, is a creation of the National Health Act 2014, and it simply gets 1% of the Consolidated Revenue Fund to be shared through 4 gateways, through the Health Insurance Agency, and National Primary Healthcare Development Agency, the Nigerian Center for Disease Control, and the Emergency Fund. So it's currently over 8,000 primary healthcare centers, 1 per ward, have been given direct funding. Direct funding simply means from CBN straight to the account of those primary healthcare to fund their basic needs. Some medicine and consumables to supplement if there is shortage of human resource for there. They can hire people on ad hoc basis to provide. If there's a problem of light, they need to do some wiring. If there's a repair of pumps or their source of water, and also keep the health facility good for access to people in the community. In addition to going to the community to mobilize people, to get them aware that these services are now available closer to you. So that is ongoing.
Are there places right now that yes, you can talk to us, that maybe if you say, okay, if you go to maybe Karu or Nyanya or somewhere in Lagos or this, yes, you will get one of the healthcare centers that you have probably made accessible, yes, that people can visit and get exactly quality health care. Exactly. You remember what Professor Lainka said, it's yes, not just the distance, it's also getting the quality care and all that. So do we have such at the moment that you can boast of?
Yes, we do have. Every local government, an average of 10 wards in every local government, meaning that we have an average of 10 of such facilities. 1 per ward. Some of them are undergoing upgrade and refurbishment, but we have already done that. Over 8,000 of them are in the pool and currently running. Somebody mentioned the issue of shortage of skilled manpower. It's across the country. Some of those facilities experience this, but as soon as we know, we make intentional actions to make sure that we cushion such a shortage. Also working with the state primary healthcare development agencies of all the 36 states. These are easily made up for. But still, we need more. We need more because like we wanted more women to have access to skilled birth attendants, which currently in our rural areas is at about 30% compared to 70% skilled birth attendants in the urban areas. But let me quickly say something to address some of the issues raised by Professor Olainka. When this government, the current administration came in, we did a diagnostic workshop of the health sector. What is the problem? Why are we not getting results for the investment that we had? And all stakeholders were part of it. This took place around September 2023. And it was from that workshop, the Health Sector Renewal Investment Initiative they're currently operating, we got the backbone on 4 pillars. One, there is need. From that workshop, we rose with a resolution, there is need to improve the governance of the health system. Improve governance. Management at all levels, being accountable, doing what they are supposed to be doing, and of course, ensuring that Nigerians get the needed quality for what they seek. The second one is to improve population health outcome. This has to do with service delivery, making sure that whatever services Nigerians access in when they visit any of these facilities is of the appropriate quality. And more importantly is the third one, unlocking the health care value chain. From our experience from the COVID pandemic, we all see that everything we needed, most of the things we needed, had to be imported. So this government has taken it upon itself to set up what we call Presidential Initiative on Unlocking Healthcare Value Chain, the acronym PVAC. What do? Most of the consumables and essential medicine that we use regularly in Nigeria are now to be produced in country through two ways. Bring the factories, companies that are producing them abroad, to come and establish factory here to produce. Some have started. And in addition, get technical partnership from these foreign companies to support local manufacturers to produce some of these generic products. Because the National Health Account Analysis of 2022, which result came out in 2023, just about the time the government came into, showed that 70% of household income on health goes on malaria. And most of the malaria products are imported. So now local manufacturing has brought down the price, and then we are making sure that some of these medicine are available at these PHCs, especially the ones of basic healthcare.
But how have all of these impacted affordability? Because, I mean, Prof made reference to someone who died recently, a pregnant woman, simply because the husband was requested to deposit 500,000 naira before they would give them attention, and that lady died with her pregnancy. Now, with over 70% of healthcare spending still out of pocket, how does the Ministry of Health plan to scale up, insurance, especially in rural communities?
Thank you very much. We mentioned that there are reforms going on in the health insurance sector. In the last 1 year, we were able to add 2 million, and this is with the cooperation of the 36 states of the Federation and FCT. In terms of affordability, we also brought up a report that showed that many women that needed cesarean section from the rural areas end up either losing their babies or losing their lives just because they could not afford cesarean section. So this government has launched what we call maternal and child health, maternal and child mortality reduction innovations and initiative that we call MAMI, meaning that if a woman who is pregnant wants to deliver, and at the PHC they found out that this woman may have difficulty in delivering on her own, that she will need a surgical intervention, which is what we call the cesarean section. Any hospital she goes to, she will have access to cesarean section without necessarily paying. If she cannot afford this, she will not be denied the cesarean
Please,
section.
can you repeat that again? So that, yes.
Any facility, as we speak now, all our tertiary health institutions, teaching hospital, FMCs
across the country
have been directed to attend to any woman who has a need for cesarean section and cannot afford. That cesarean section must be done. They will now get the bill calculated for submission, and this will be paid for by the national.
But how many
health.
are they? How many are they? Because by the time you swoop on these facilities, how many are they able to attend to in a day?
A journey of 1,000 miles starts with a step. We have identified this need. We need to tackle it, and now we have started. Now, process is ongoing with the National Health Insurance Authority to identify private health facilities who have that have the facilities to provide cesarean section to come into this space, because many of these private health facilities are closer to these women than the big facilities. And we are also talking to the state governments, who are the owners of the general hospitals, which are present in virtually all local governments, to buy into this scheme and also use that as an avenue to implement their own health program for their people.
Thank you.
I will just assure you, we have started. Let us watch how it pans out, all right? And then we receive feedback on how to better improve it. Not starting at all is not an option.
I agree with you. Not starting at all is not an option.